Ladies and gentlemen, thanks for logging into this year's AAO Uveitic Glaucoma Mechanisms and Management course. This course is jointly run by myself, Keith Barton from Moorfields Eye Hospital, and someone who needs no introduction, Gary Holland from Stein Eye Institute in UCLA. These are my financial disclosures. I work with a lot of primarily glaucoma device companies. Although I shouldn't have any speak of any off-label products in this talk, it is almost impossible to talk about surgery in uveitic glaucoma without going off-label. But nevertheless, I'll do my best. Uveitic glaucoma, it illustrates all the extremes of glaucoma. It has a mixture of mechanisms, mixture of pressure, extremes of pressure, conflicts in medical treatment, difficult surgery, and Gary and I will attempt to elucidate, rationalize some of these in this 1 hour. I will speak briefly in mechanisms. Gary will talk about the management from a uveitis specialist perspective, and I will talk about management from a glaucoma specialist perspective, especially surgery, and then we'll sum up at the end. The mechanisms of IOP elevation and uveitis are mixture mechanisms, both corticosteroids, inflammation, angle closure, and even probably the viscosity of the aqueous in many cases. On the other hand, unlike other types of glaucoma, there are mechanisms opposing IOP elevation. You can have quite dramatic ciliary body inflammation, ciliary insufficiency, ciliary detachment, or even ischemia. So the net result may be very, very little aqueous outflow, but very, very little aqueous inflow as well, and therefore rather dramatic swings in pressure. In terms of mechanisms, it's important from a clinician's perspective to elucidate what's actually causing the high pressure. One type of uveitic glaucoma requires separate consideration, and that's acute angle closure with a secluded pupil. And I'm highlighting this specifically because it's very dramatic, occurs in young people, often in both eyes, and is potentially blinding, and is very, very different from the primary angle closure that we're all used to in primary angle closure glaucoma. It's important, therefore, to differentiate what's causing the angle closure. And they break up roughly into 3 groups: pupil block mechanisms, chronic angle closure mechanisms, and some central anterior chamber shallowing mechanisms, such as forward movement of the lens iris diaphragm or phacomorphic glaucoma. I can't emphasize enough how much they differ from primary angle closure. This is relative pupil block from primary angle closure, which in itself is dramatic and blinding in many cases with relative pupil block. But compare this, the dramatic absolute pupil block of uveitis, where there is no aqueous at all getting from the posterior to the anterior chamber. And the iris is not only bombayed, but it's actually plastered against the cornea. And this is a rather dramatic condition, much more dramatic than even acute angle closure, and hence the importance of emphasizing it. And it is important to differentiate all these different types of angle problems. And overall, it's essential to look at the angle in uveitis. Chronic angle closure, you can determine simply by gonioscopy. And you've got to differentiate those broad anterior sneaci from the occasional bridging sneaci that you get here from an acute anterior uveitis attack. You can occasionally make a diagnosis from the angle alone. The sarcoid nodules in the angle in the ciliary body of this young black man that I once saw presenting in the emergency room with acute anterior uveitis. Or sometimes there's nothing to see in the angle except a little pigment. And perhaps this is more a steroid response than the actual uveitis. So there are various different aspects to consider. Gary will talk about the types of pattern recognition that you might encounter, but in my practice as a glaucoma specialist dealing with the glaucoma, the Fuchs uveitis syndrome, which is becoming less common, herpetic keratouveitis, and the so-called Posner-Schlossman syndrome are typical clinical patterns that produce open-angle types of glaucoma and uveitis. Why do I highlight Fuchs? Because in my practice, it was very often misdiagnosed, or the glaucoma potential misunderstood or underestimated. Yet it has very characteristic clinical features, commonly causes recalcitrant glaucoma requiring surgery, and filtration surgery is often less effective than in other types of uveitis. We're always taught as residents the importance of looking at the spindly KP evenly distributed all over the cornea. But to be quite honest, in my experience, the iris appearance is much more characteristic with these nodules at the pupil margin in pigmented races, or nodules in the iris stroma, or this remarkable transillumination that blue-eyed patients seem to get with the pupillary membrane that never seems to cause synechia, except in complicated surgical cases, and this diffuse loss of iris pigment epithelium. Even though there's loss of anterior stroma, it seems to be posterior pigment loss that causes this dramatic diffuse transillumination that looks like nothing else that I've seen in glaucoma. Contrast with the iris transillumination and the severely damaged sphincter of recurrent acute anterior uveitis, which is clinically very different. Contrast with pigment dispersion syndrome, where the iris stroma is actually pretty normal, the pupillary sphincter is normal, and the transillumination is very even. And don't forget the dramatic propensity for Fuchs to cause floaters that can often be visually incapacitating and frequently lead to vitrectomy for floaters and sometimes a consequent elevation in pressure. Posner-Schlossman type conditions, on the other hand, show very little. Occasionally, one sees a keratic precipitate or a few cells in the anterior chamber, but the clinical diagnosis is really of the dramatic swings in pressure. And in Fuchs, this is slightly out of order. The dramatic angle vessels, which are not seen very often and rarely seen as frequently as this, but particularly diagnostic when they are seen. And at this point, I'm going to hand over to Gary to give a uveitis specialist perspective. And this is an area that is not my expertise in any way.
Thank you, Keith. I am going to go over some of the same topics, but from a uveitis specialist perspective. I have no financial disclosures, and I also will not be discussing off-label use of drugs or devices. So here are the topics that I'll cover. I am going to discuss a little bit about epidemiology, the types of uveitis that have elevated intraocular pressure, which is important for evaluation, some comments about monitoring pressure and optic discs, management primarily in terms of the medical management, but some of the considerations as far as surgery, but not technique. With regard to the frequency of uveitis, here's a nice study from Northern California in which they showed that across the board, about 15% of patients with uveitis have elevated intraocular pressure. But as you see here, the risk goes up markedly when one compares chronic uveitis to acute or recurrent disease. Elevated pressure can be either a feature of the disease itself, or it can be a response to corticosteroid treatment. But as you see here, the largest subgroup of patients actually have elevated pressure from both mechanisms, which adds some complexity to management decisions. The cumulative risk of uveitic glaucoma may be even higher in children. In a study that we did at UCLA, we found that the risk of uveitic glaucoma in children with chronic anterior uveitis was approximately 40% after 8 years of disease. That shows that in general, elevation of intraocular pressure is a late complication of chronic anterior uveitis, and our studies have indicated that it's more closely related to elevations of flare than elevations of cell. Here are two studies showing the relationship of glaucoma with elevated flare levels as measured by laser flare photometry in the graph on the right. And the relationship seems to be with outflow facility as shown in the study on the left. But there are cases in which intraocular pressure goes up early at the onset of inflammation or during exacerbations of inflammation. We've already heard about Posner-Schlossman syndrome from Keith. Elevated pressure is, of course, a part of the syndrome definition. But as far as specific disease entities, sarcoidosis can have elevations of pressure with an exacerbation of inflammation, but primarily high pressure at the onset of disease is a feature of infectious forms of uveitis. Herpetic anterior uveitis, toxoplasmosis, or syphilis are the classic examples. And in these disorders, treatment with corticosteroid therapy, even without glaucoma medicines, will cause a fairly rapid drop in inflammation, which suggests that it's related to inflammation of the trabecular meshwork and the outflow channels. Also, the high pressure in these conditions isn't always related to the level of anterior chamber cells. So someone can have a minimum amount of cells in the anterior chamber and yet have very high pressures. That can be seen in herpetic anterior uveitis, for example. In terms of monitoring, there's some special considerations when you're dealing with someone who has uveitis. As with these specific diseases that I mentioned, with exacerbations of inflammation or with intermittent courses of corticosteroid, you can have spikes in pressure even when you're not seeing a patient. And these spikes can lead to optic nerve damage and yet not be picked up if you're just periodically monitoring intraocular pressure, which emphasizes the importance of monitoring the disc and the visual field in uveitis patients. And there are special situations where you need to pay particularly close attention to pressure. Chronic use of steroids, obviously, and especially if those steroids are in the form of a fluocinolone acetonide implant, in which patients, the majority of patients will have increased pressure and may need glaucoma surgery. And then there are some specific disorders. I've mentioned those infectious diseases that can have pressure spikes, and Keith has talked about Fuchs uveitis syndrome, in which elevated pressure is very common during the long course of the disease. So here are some considerations in terms of managing the uveitis itself. It's very important to control anterior segment inflammation in those with chronic disease early and aggressively to prevent damage to the outflow facility that leads to glaucoma. Our strategy for managing chronic uveitis is to get disease into control initially with corticosteroids, but maintain that control with immunomodulatory therapy rather than corticosteroids. I want to also mention something about treatment of uveitis in corticosteroid responders, and we'll talk about when to start glaucoma medications in the course of uveitis management. So, as an aside, let's talk about the role of corticosteroids in relationship to uveitis. We've mentioned that steroids can cause increased pressure. I've also mentioned that it can be a treatment for increased pressure in those acute exacerbations of disease. But another important consideration is that it can be a confounding factor for the interpretation of changes in pressure. And I'll come back to that in a minute and explain what I'm talking about as a confounding factor. As far as the pressure elevating effect of corticosteroids, this is a nice study from a few years ago that showed that there's a relationship between pressure elevation with the route with which steroids are administered. Again, the very high risk of pressure elevation with steroid implants versus systemic steroids. But another important point is that there is a dose effect with topical steroids, as shown here. Uveitis specialists in general will not use topical steroids more than a couple of times a day, but this graph from this study shows that even at 1 drop a day, there is a small increased risk. So if patients require long-term minimal steroids, they do need to be monitored for eventual pressure elevation. Now, as far as that confounding effect, there is an inverse relationship between levels of inflammation and intraocular pressure. This graph shows that as anterior chamber cells go up, there is a lowering of pressure, and presumably this reflects inflammation of the ciliary body and decreased production of aqueous, although that hasn't been proven. You'll notice that the effect is small. There's a small reduction in pressure even with marked increases in cells. So getting back to the management, we've talked about the fact that pressure will go down in selected conditions at an exacerbation of inflammation, but a steroid challenge in patients with chronic disease almost never works. So a steroid challenge in an attempt to reduce pressure as it goes higher and higher over time is rarely, if ever, effective. I sometimes see patients being referred in who have corticosteroid response, and they've been switched to a weak steroid like loteprednol. But I don't consider that a good strategy because the weaker steroid won't control inflammation as well. Patients end up with smoldering disease that eventually results in worse disease-associated glaucoma because of ongoing tissue damage. So the alternatives in a corticosteroid responder are, as I said, immunomodulatory therapy as steroid sparing treatment, but also occasionally, if patients can't be on immunomodulatory therapy or they have profound steroid-induced ocular hypertension, we'll actually consider glaucoma surgery to allow them to be on local steroid therapy. But again, that is not a preferred strategy. And then assessing the effect of corticosteroids on pressure. It's complicated by the fact that increased inflammation can cause a drop in pressure. And so following treatment with corticosteroids and control of inflammation, we'll see a rise in pressure as inflammation goes down. It's returning to its level before the exacerbation, but this shouldn't be interpreted as a corticosteroid response. And that's where it becomes confusing for some people. The pressure will go up a little bit as the inflammation is controlled, and it's going up at a time when you've increased corticosteroid therapy to achieve that control. And so it looks like a steroid response when it actually is not. So you don't want to misinterpret that effect. Now, if the pressure goes way up, that's probably not this confounding effect that I've mentioned, because as I said earlier, this modulating effect of inflammation is relatively small. So just to review these points about managing elevated pressure from the uveitis specialist perspective, corticosteroid response is common, but disease-associated uveitic glaucoma as a complication of chronic uveitis is probably even more common. You don't want to sacrifice control of inflammation to lower pressure with the assumption that all pressure rises are a response to corticosteroids. You don't want to switch to weak steroids because it will ultimately lead to smoldering inflammation and in the long run, a higher risk of uveitic glaucoma. Most important from the inflammation standpoint is to get patients with chronic disease onto immunomodulatory therapy if they've got non-infectious uveitis. Methotrexate being the drug that we use most frequently as the first agent. As another aside, I want to review this management pearl, and that addresses the question of if a person with uveitis presents with nearly secluded pupils, should a laser PI be performed immediately, which is kind of a knee-jerk reaction amongst a lot of ophthalmologists. The problem is that if someone has an almost secluded pupil and yet normal pressure, if you do a laser PI, you can actually induce angle closure glaucoma as occurred in this patient. So the answer is no, and here's why. Paradoxically, the laser PI will precipitate angle closure. Pupils will almost never completely seclude if the patient is on adequate anti-inflammatory therapy because there's such a high pressure of fluid going through the remaining opening that it won't ever, the iris won't oppose that last little segment to the lens to form that final seclusion. But if a laser iridotomy is performed, pupillary seclusion will occur because there's a high risk that the laser PI will close. And since the fluid has been going through the laser PI and not through the remaining opening at the pupil, they will both be closed. Iris bombée will occur and angle closure will ensue. So last January, Keith and I published an editorial in the British Journal of Ophthalmology discussing this study by Betts that gave some proof to this procedure that we've adhered to through the years. And so I refer you to these two documents to expand on this idea a little bit more. But I feel strongly that in patients, and again, it's important that these are patients with controlled uveitis. If they have a nearly secluded pupil, they do not need a PI. If they do, for some reason, need a PI, if the inflammation's not controlled, for example, you really should be doing a surgical PI. The Betts study showed that they are much less likely to close off over time. As far as glaucoma medications go, as I said, once IOP begins to increase in chronic anterior uveitis, it's almost always permanent. Corticosteroid treatment of the inflammation is not going to lower the pressure, and they need glaucoma medications. So there are some considerations that are unique to uveitis patients. In years past, we've talked about pilocarpine actually being associated with increased risk of problems in uveitis patients because of the small pupil and the possibility of synechia formation on that basis, further breakdown in the blood eye barrier with pilocarpine. But that's really of historical interest since the drug is not used much in glaucoma management anymore. But the two drugs that we think about most in terms of uveitis are bromonidine in children. Generally, glaucoma is not a disease that one's treating often in children, but we have to remember that in this population, if they do need glaucoma medications, we don't want to use bromonidine if they have small mass because of respiratory suppression, and it can induce somnolence as well. The other drug about which there's a lot of discussion is prostaglandin analogs. In cataract surgery, it has been associated with inflammation and CME, but I haven't found that to be a problem in uveitis patients. A bigger problem is that it's simply not going to be effective. If someone has active uveitis, they already are pouring out prostaglandins as a compensatory mechanism, and the addition of prostaglandin analog is probably not going to have much effect. But once the inflammation's controlled, it does seem to be useful. So it's not our drug of first choice, but we will use it in someone whose disease is controlled. And then more recently, rapazudil has been shown to be effective in patients with uveitis. So that's an additional drug in our armamentarium now. A few special situations for monitoring. Treatment failures are more common in patients with uveitis. Medical treatment is more common among uveitis patients. So we frequently find ourselves having to escalate medical therapy with multiple drugs, and oftentimes patients have to proceed on to surgery. And then after surgery, we often have to reintroduce medical therapy. And in terms of the surgery, Keith will get back to that in a few minutes. And then another pearl, management pearl, if patients have ciliary body atrophy, which can occur after many years of anterior and intermediate uveitis, we find that patients can have very wide swings of pressure with any change in medication. So we'll sometimes have patients still on glaucoma medications when they have a very low pressure, and the tendency for non-glaucoma specialists is to stop those glaucoma medications, and their pressure can shoot from very low to very high just with minimal changes in the medications. And that's probably because they have both limited aqueous production and limited outflow. And so any change in that dynamic can cause wide swings in pressure control. So in patients with long-term disease and low pressure, be very careful with making big changes in their glaucoma medications. Children have additional considerations. I've mentioned the risk of some medications, but also we find from experience that glaucoma in children occur earlier and it progresses more rapidly than in adults. Manifestations can be more severe, and they're more likely to have steroid-induced ocular hypertension as well. Monitoring children with uveitis, especially very young children, can be problematic because of their inability to participate with visual field testing. So it's especially important to periodically examine their fundi for optic disc changes or do monitoring with imaging using OCT for optic disc changes rather than relying on visual fields alone. We start children trying to do visual fields about age 7, and they may not be reliable at the beginning, but if you keep them practicing, we then eventually start monitoring children with visual fields as well. So to conclude my part, one thing we've done each year is I've brought up what's been published in the literature in the year since our last course. And I've pulled out a handful of different topics that have been found in the literature over the past year. They include continued study of the pathophysiology of uveitic glaucoma. There was a recent article that studied aqueous humor dynamics that again showed reduced outflow facility. In the study I mentioned that we had done, it was in people that had active uveitis. It's also been shown in people after their uveitis has been controlled, which again speaks to the fact that uveitic glaucoma eventually occurs as a late complication of disease. There's greater diurnal variation in pressure and higher peak pressures in people with uveitic glaucoma than in those with chronic open-angle glaucoma. And it just points to the fact that uveitic glaucoma is a different disease and has different considerations. One point that's been made in a couple of papers in the past year is that among uveitis patients, there will be increased retinal nerve fiber layer thickness, which may interfere with glaucoma evaluation if you're monitoring the nerve fiber layer in terms of glaucoma. With regard to medical therapy, additional studies have really made that point that early treatment of uveitis with immunosuppressive drugs will reduce the risk and severity of uveitic glaucoma. And then rapazidil as an effective pressure-lowering agent in people with uveitic glaucoma, but also corticosteroid-induced ocular hypertension. In terms of surgery and laser therapy, there have been articles showing that selective laser trabeculoplasty and transluminal trabeculotomy procedures can be effective in reducing pressure in eyes with uveitic glaucoma. But it's important to note that these studies have been small case series and they've been of short duration. So we still need to monitor these patients very closely after these procedures, even if their pressure has come down. A study that Keith may mention, I know he's talked about it at other presentations, is the fact that Barvelt devices are associated with greater IOP reduction in eyes with uveitic glaucoma than OMED valves, but are associated with more complications. And then in terms of outcome, just as I mentioned earlier, visual field progression as a manifestation of glaucoma is more rapid in people with uveitic glaucoma. And with regard to one specific group of diseases, the herpetic anterior uveitis, CMV, anterior uveitis is associated with a much higher risk of glaucoma than herpes simplex or VZV, anterior uveitis. So with that, I will sum up by giving my key points, which are glaucoma is a common complication of chronic anterior uveitis, and that the mechanisms and course differ from other forms of glaucoma. Our goal is prevention of disease rather than treatment. Corticosteroids can contribute to the control of inflammation in selected cases, primarily the infectious uveitis. The choice of medical and surgical management may be different than patients with chronic open-angle glaucoma. Patients need to be closely monitored regardless of the treatment chosen. And with that, I'll turn it back to Keith. Thank you.
Thank you very much, Gary. Gary's really already alluded to how medical treatment of elevated IOP is managed in patients with uveitis. I mentioned very briefly how it differs from POAG, because it's really just reiterating what Gary has already said. Obviously, from the uveitis specialist perspective, reducing steroids to help the IOP is a false economy, and this is something that glaucoma specialists are tempted to do, but must not. Another thing that glaucoma specialists are tempted to do is give a lot of prostaglandins, because that's what we do in POAG. But in fact, I tend to avoid them personally in patients with macular edema, because I fear that if you've already got macular edema, they may not be good. And I really don't feel that they help the pressure control. There is some evidence in non-steroidals topically may block the IOP lowering effects of prostaglandins and alpha agonists. So topical non-steroidals may be best avoided if possible. There is a clinical impression shared by many people in uveitis fields that aqueous suppressants work better, simply, I think, because the ciliary body is more sensitive. And Gary has already mentioned the importance of not underestimating how it can swing on medical treatment. And Gary mentioned that uveitis specialists may not be aware of this. Glaucoma specialists are not aware of it. I have one or two patients. Fortunately, the patients who get dramatic IOP swings tend to be aware of it themselves and warn the doctor. I have patients who on Trusopt once, twice a week and things like this, because if you put it any more than that, the pressure was very low. I have patients who can go from pressures of 40 to 2 with one dose of medical treatment. These patients in general are very aware of this problem, and it is important to listen to them if the patient tells you that. I mentioned just in passing brimonidine allergy, which if undiagnosed can actually cause chronic granulomatous anterior uveitis, and that can be confusing. It's less common these days. I think more people are aware of it. Gary pointed out that his job was to prevent uveitic glaucoma. My job, when I was asked to set up a glaucoma clinic, was to take pressure out of the equation so that the uveitis specialist could do whatever he thought was necessary. And unfortunately, in most of the patients, that meant surgery, really, because taking pressure out of the equation non-surgically is very tricky indeed. It's always in the equation. Unless you had a very good functioning trabeculectomy or tube, pressure was always in the equation. I go back to angle closure briefly because it's so important. And before we surgically manage the pressure, clinching the diagnosis, forward movement of the lens iris diaphragm with a very shallow central anterior chamber compared with pupillary block with a very deep central anterior chamber. Forward movement is usually iatrogenic, gas, buccal, aqueous misdirection, or it can be due to a big lens, in which case the lens is taken out. The classic cases of posterior scleritis and VKH are actually relatively uncommon in my practice, but probably a lot more common in Gary's practice. In order to take pressure out of the equation, I have to try and prophesy what the long-term effect will be. This is a condition with episodic pressure elevation. So you've got to predict if the patient's pressure goes back down to normal. Is it going to go back up again? Is it going to be up? Is it going to cause them optic disc damage or not? And there are really two factors apart from the type of uveitis that I use to predict the long-term need for surgery. And one is what the angle looks like. An angle with broad anterior sneaky looks compromised is much more likely to need surgery than an angle that is wide open and like the clear angle I showed earlier. An angle, this type of angle I'm talking about, it's not rocket science that this angle is compromised. The occasional anterior sneaky eye bridging from an acute anterior uveitis may be less significant. Other things like membranes, neovascularization are important. And so I use that as a predictive factor. And the other factor I use is the optic disc appearance. In glaucoma practices in general, we operate surgically for people with bad optic nerves. In glaucoma and uveitis, we don't. We operate on people with very high pressures and relatively mild disc cupping. And when young patients started to develop disc asymmetry, that's telling you that the optic nerve is being damaged, even if the pressure is back down to normal in between attacks, and you're more likely to need surgery. Then acute angle closure is much less common, but as I've tried to highlight, as Gary's highlighted, it really is a surgical emergency that needs to be taken very seriously indeed. Laser PI is often ineffective, partly for the reason Gary mentioned, but because the aqueous is often loculated. And this 47-year-old Hispanic female who developed localized Bombay, which disappeared in some quadrants but not the others, unintented dilation, is a good example of how the posterior chamber is not a continuous space in eyes with secluded pupil. Not only that, is the iris is very adherent all over the place. And while there may be loculations, sometimes the Bombay is just a very, very thick iris. There's all sorts of reasons why laser iridotomy can be ineffective and delays the necessary surgical treatment. On top of that, as I showed earlier, if the iris is plastered against the cornea, then you're lasering the endothelium. And remember that when the iris is plastered against the cornea, this is not like primary angle closure where an iridotomy will allow the iris to fall back. The iris in these sticky fibrinous situations is adherent and doesn't fall back. So if you don't physically unstick the iris from cornea or from trabecular meshwork, it doesn't fall back. This is a good example. This is a patient with 3 iridotomies, no iris Bombay persistent, but the drainage angle is completely closed. If this were primary angle closure, the laser iridotomies would have allowed the iris to fall back. But in uveitis, the iris is sticky and adherent to the trabecular meshwork and doesn't. So you need to go in and actually physically separate it using viscoelastic, assuming that the sneaky eye are relatively recent and not permanent. And Gary's already mentioned these publications, so I'll move briefly past them. This video shows that just how adherent the iris can be. This was my traditional method of doing surgical iridectomy through a small peripheral corneal incision. And with a lot of viscoelastic and a lot of mobilization and a lot of bleeding, the iris is eventually mobilized and the iridectomy performed. But for the interest of time, I'll keep moving. It's much easier to do a surgical iridectomy using a more peripheral incision and a more remote incision I'll show in a moment. But surgical iridectomy allows you to break posterior synechiae, which isn't essential and may be traumatic, and they may reform. But ironically, posterior synechiae to the actual crystalline lens are often less adherent for some reason than posterior synechiae when there's been cataract surgery to the anterior capsule. And you can see here, trying to release these is actually just very traumatic, and you don't really need to do it, and they may reform. And that's some blood from trying to release the synechiae. But what you can do with surgical iridectomy, and this is probably the single most important benefit, is that you can visco open the drainage angle and separate the temporarily adherent iris from the trabecular meshwork so that chronic synechiae do not form. Not breaking chronic synechiae, you're preventing them from forming. And this is what laser iridotomy does not permit. And this allows you to open an angle that would otherwise not fall back. You can then do the surgical iridectomy from a remote MVR incisions using vitrectomy forceps and scissors, which is a simpler, more elegant way if you have these instruments available. And this allows the good visualization because you're not opening up and you're not relying on a wound right over the iridectomy. And you can cut a little flap in the iris, but then very often that little tag, you need to reverse the instruments to remove the little tag. And like so. This is a very simple but more expensive way, but quite elegant way to do an iridectomy. But arguably the most useful thing you can do is actually the viscogoniosynechiolisis, and obviously treat the patient very aggressively with steroids to prevent everything reforming. So the reason for not doing a laser iridectomy here is this case where you've got patent iridectomy, loss of Bombay, but the angle's still completely closed, so you haven't really fixed the problem. What about actual goniosynechiolisis? I talked about viscoing open temporary adhesions, not permanent ones. This is a young Canadian girl, a 23-year-old who had a goniotomy in childhood and did not need a tube for 15 years. So goniosynechiolisis of an open angle in childhood, not goniosynechiolisis, but goniotomy, not goniosynechiolisis, in a young person has been reported to be beneficial. And modern day types of ab interno trabeculotomy that do roughly the same thing. But remember that if there are anterior synechiae, these have a negative impact on success. So goniolysis or goniotomy really only works in young people and those with wide open angles, not those with synechiae. And Gary's already emphasized the importance of not lasering the subtotal secluded pupil. So it's important to identify the mechanisms and risk profile angle closure patients. And it is very important to look at the angle. What about when it comes to filtration surgery? Although Gary's mentioned SLT, there has been some evidence that may be beneficial. In general, if you've got very high pressures, you have to be realistic about what you're achieving. And SLT will not produce huge pressure drops. So then is it trabes, or something else? Well, trab has a bad history in uveitis. And that was a publication from Moorfields in the mid-90s. But these patients were not well managed. And I say that coming from Moorfields. They left the uveitis clinic for the glaucoma clinic and then got lost in the melee of glaucoma patients. So their uveitis was not managed well. Why do uveitic trabs fail? Ongoing inflammatory episodes, conjunctival inflammation, and cataract. And cataract's perhaps the biggest obstruction or biggest confounding problem, because to the patient, cataract surgery is vision restoring, and cataract is very common in uveitis. But on the other hand, if the pressure is very high, waiting to do the cataract is also a false economy, because it may cataract surgery in a patient with high pressure can exacerbate the high pressure, and then you're forced to bring the patient for a filtering surgery in a hot eye. So sometimes it's better to do the filtration surgery first, allow the eye to settle down, and make the patient wait 6 months to do the cataract. It's very important not to delay cataract surgery in a patient with high pressure. And that sounds like I'm saying directly the opposite of what I've just said, but I have seen young people who have been left until cataract surgery suited them, because it was inconvenient to do cataract surgery. And by the time the cataract came out, there was no optic disc left because the pressure was high and it wasn't really taken seriously while the cataract was in place. So if you're going to delay cataract surgery, get on, do the glaucoma surgery and make sure that the pressure is controlled. Filtration surgery actually does work well in carefully selected cases. These patients have a higher propensity to hypotony. You need to put more sutures in the flap. But in our audit in the 1990s, at 4 years, which was the median in this group of nearly 200 patients, we had roughly an 80% success rate. The ones that did worse, ironically, were the pseudofakes. And at the time, it was thought that this may be because some were extra caps or some were scleral tunnel phacos, but they weren't. They were clear corneal phacos, and they did worse. And of course, there's a huge potential ascertainment bias here. These patients that did worse and were pseudophakic may just have had worse uveitis to start with. We don't know. But overall, this group on our audit did better if they were phakic to start with, even if they needed subsequent cataract surgery. The advent of subconjunctival MIGS has changed things, although these are not licensed, as I must emphasize, for uveitics. One could argue that a very well-controlled uveitic who has no other risk factors for failure is actually a good candidate, because often their disc damage is not severe and their pressures are high. And I found that in people, I tend to reserve Zen and in-focus microshunts for patients with less severe glaucoma. So they don't have very bad optic nerves because they don't get quite as low target pressures as trabs. But on the other hand, if they have high starting pressure, that's fine. And this is a sarcoid uveitic, 37-year-old white sarcoid uveitic, untreated at 60 millimeters of mercury, 28 on Diamox, 2 years post-op, 19 on no meds except dexamethasone. And we wrote this series up in Clinical Experimental Ophthalmology, and there was a few years ago, and there was an accompanying editorial. The in-focus microshunt seems similar. It's important, though, if you're going to use subconjunctival MIGS, these are filtration procedures, and they suffer from the same risk factors for failure as trabeculectomy, such as patients who with ethnic risk factors for failure, other risk factors for failure. They don't do so well. They do less well than trabs in higher failure risk patients. And this was a microshunt series in uveitics that we presented at the American Glaucoma Society during my last ever plane ride in March to an overseas trip. What I do when no failure risk factors, high pressures, relatively healthy discs, then if there's really no other failure risk factors, a Zen or a microshunt. No failure risk factors, high pressures, bad optic nerves, I still do a trab, because actually the trab still gets lower target pressures than tubes, although one does have to watch out because in uveitics, the low target pressures can be very low indeed if you're not careful, and you do need to put in extra sutures. So that's high IOP but mild glaucoma. This is more advanced glaucoma. That's if there's no failure risk factors. Patients, significant failure risk factors, tube. Everyone accepts that tubes work better in uveitics, and it's popular to put amide valves in uveitics. But as Gary mentioned, I think tubes in uveitics across the board do well. But again, these are apples and oranges, and they behave very differently. A patient who's had severe JIA from 3 years old will behave very differently from an acute anterior uveitic who's had it since their 30s. The patient who's had it since their 30s or 40s will actually often require a 350 Barvelt to control well. And unless the inflammation has been very, very severe, is very unlikely to get hypotony. The JIA patient has a very high risk of hypotony from the Barvelt and even the armored valve. And I still use the somewhat obsolete single plate Multino in these patients. And the question I ask the patient is usually, what age did you get the uveitis from? The patient comes to me and they're 35 years old. They tell me that the uveitis since the age of 3 or 5. These are the patients that I'm very cautious on and put the small implant in. If they've had the uveitis from adulthood, I'm more cavalier with the plate size, and I will most likely go for a 350 Barvelt, as that in the end does do the business and get good pressure control. So they're very different. Other risk factors for failure, remember, single chamber eyes are different. They really need to go to the tube. Any form of neovascularization tube, previous retinal attachment surgery tube. But yes, there are publications clearly showing that even though these are large case series and are not, or even small case series and not comparative, I think it's well accepted that tubes work well in uveitics, and it's really identifying which tube for which uveitic. And unlike POAG or other types of glaucoma, where my standard approach is pretty much one size fits all, it's a 350 Barvelt. In uveitis, I do stratify them: JIA, or any severe chronic uveitis from early childhood, or what we do not see anymore, congenital cataracts that were needled in childhood. And I don't know how Gary feels about those, but my experience from the past, they seem to behave very much like chronic uveitics and seem to have the same risk of hypotony with tubes, and I would use a single plate Multino or a Barvelt 250 or an armored valve. But my experience with some of these very severely damaged ones, even a Barvelt 250 or an armored valve can be too much. But on the other hand, and this is one, and we see them less commonly aphakic these days. This is a one-eyed aphakic JIA patient in her 20s, where I think this was a Barvelt. It must have been a 250 Barvelt. Has kept her well controlled since I implanted this in 2001, I think. So about 19 years later, she still comes. She has a bad optic disc in her only eye, but she still sees 6/9, is well controlled. And that's a single plate Multino. So for a summary of what I do when and surgically is my remit was to take pressure out of the equation whenever I could. Acute angle closure, surgical, not laser PI, so that I can visco open the angle. No failure risk factors in open angle glaucoma with high pressures and discs that are not severely damaged, Zen or microshunt. No failure risk factors, high pressures, bad discs, trab. Significant failure risk factors, tube, and you've already heard how I select the cases. It is not one tube fits all. These behave very differently. And thank you so much for your attention. And we hope to get back to, I hope to be able to get back in the plane to the US next year and meet up with Gary.